Thank you to all the families that are here today. Thank you for hosting me, for inviting me. I tried to try and understand what happens when children present this kind of symptoms, especially those with the GNAO1 mutation, and try to understand the perspective of the families. We doctors are used to work in the hospital setting. We are used to see the patient, to do the therapy that we need to do. But then at home, the patient or the parent of the patient in this case has to face daily challenges, has to deal with some situations that are not very common. And the question is, do we have the tools? Are we equipped as families to face the challenges that come with this gene mutation? So very quickly, the status dystonicus was described quite recently. The first description dates back to 1984, and since then there were reports where this status dystonicus was classified with different terminology. So there were desperate dystonics or dystonic storms, up to 1998 when a work was published, and from that point on, there was a quite widely accepted definition of status dystonicus. However, the scientific community does not agree on the definition. What we know and what we agree on is that it's an important condition. It's a condition that requires hospitalization, and children are more subject to having status dystonicus. We often say that this is a rare condition, but maybe is not widely recognized, dystonia. Maybe the condition is not that rare, but it's hard to recognize, to identify. The scientific community doesn't completely agree on the definition of status dystonicus. Even recently, there were some new definitions that were proposed on hyperkinetic states. Situations where you had hyperkinetic children that need hospitalization and so on and so forth. However, this is not the goal of today's conference, to talk about definitions and how doctors want to call things. What is interesting for us today is to talk about the families, the patients and their families. We know that patients with GNAO1 mutation have to face emergencies that are due to severe movement disorders, and those who had more choreic phenotype had a higher risk of being hospitalized for this kind of aggravation of the situation. What we need is to have operational tools to give the families, to give the parents, tools, in fact, that can be used at home as well. The focus must be the domestic management of the child, of the patient. And of course, then the parents have to be in touch with doctors, with the clinicians, with the hospital. But it must be an integrated setting so that it's possible for parents to understand, for instance, when it's time to hospitalize the child or if it's possible to solve the situation at home. Let's start with the premise. There are no classifications that allow us us to do this. There are no scoring systems that allow us to say this patient has a more severe manifestation than another one. Some of these classifications were proposed, and we will see this. We will see these new methods. But we need to know the patient. The caregiver needs to know the patient. The parents need to know what the disease is like. What's the evolution of the disease? The first two stages are very important. The first two stages of the status dystonicus are important. In that case, the patient is at home. There is a stable clinical picture that can aggravate. And if it happens, we can intervene. And in that case, if it becomes more severe, more serious, the patient is hospitalized. And then there is the outcome of the dystonic state. What we need to understand is not really to understand what is needed in the hospital, this drug or that other drug. What we need is to understand what we have to do when we are at home. When do we need to call the doctor? When do we need to call Dr. Capuano, for instance, to get some advice? What do I need to say to my doctor to make him understand or make her understand what's the state and the condition of my child? For this conference, I wanted to create this acronym that I called the SPIRE approach. SPIRE stands for S for severity, P for precipitancy, intervention, re-evaluation, E for escalation. This approach can be used for every clinical setting, both at home and at the hospital. We don't have an assessment scale. The classical dystonia scales do not allow for an operational assessment, practical assessment of the patient. But since 2013, and I'm pleased to see that Professor Reina is among the guests here today. He was one of the doctors who actually created this scale. A scale that we have been using more and more recently, and maybe should be used more in clinical practice. And it is a scale that allows us to identify what. There are 5 grades in this scale, and tells us who are the patients that might need a home intervention or they need to be hospitalized in the case there is a true dystonic state. So grade 1 is a patient that is fine, as a stable clinical picture. And I want to stress how these colleagues, in a very shrewd way, immediately identified the risk factors and the practical factors that can be seen at home too. You can see, for instance, that your child is sitting with a regular posture, sleeps well, is in a stable situation. This can change if we pass it to grade 2. There might be more dystonic postures. He or she doesn't sleep well, is restless, is not able to be seated and stay seated. So it is a situation that needs a closer assessment, especially in the following days. This is a stage where we do not know yet how the situation will evolve. And this situation can actually evolve into a pre-status dystonicus. So this might be alarming. And grade 3, not all scales are perfect. Grade 3 might be that gray area where you really don't know what to do with. There is a red flag. Maybe you might regress to grade 2, or maybe not. Maybe you need to go to the hospital to be under observation by experts, by doctors. So grade 3, again, is that gray area where the parent might not know what to do. However, he might understand that there are symptoms and indication for a pre-status dystonicus, and it's better to go to the hospital. And then we have a grade 4 and 5 that are status dystonicus as we mean it as doctors, which is a situation that requires hospitalization because there is metabolic failure. There are some problems that cannot be solved at home, and these are all situations that require either hospitalization also in a regular ward, but if we have a grade 5 status dystonicus, you might have to be hospitalized in ICU because you need more invasive solutions and interventions. Again, back to our acronyms, P for precipitants, and those factors are very, very, very important. And these are the ones, the symptoms that the parents needs to inform the doctor about, especially if we are in stage 2, grade 2, there are some impairments, although the situation is not dramatic yet. And with an intervention, we can remove those triggers that might cause an aggravation of the status dystonicus. So, precipitant factors are very important, and it's something that we see very often in children. For infections, for instance, fevers of any kind might be upper respiratory airways infections, pain, gastrointestinal reflux, constipation, so a gastrointestinal discomfort. Or maybe we changed the drug therapy, or we didn't take the pills or the medicine in the correct way, so we might go from grade 1 to grade 2. And again, there might be a failure of DPS and so on and so forth. And so we move on to letter I of our acronym, and there is intervention. At that point, the parent might do something. For instance, if the child has a fever, it can be treated at home. Actually, it's better to treat it at home if it's just a fever, if the infection is not very severe. Or, for instance, if the problem is with sleep, we might help the child sleeping better with drugs if necessary, with medicines if necessary. Or if you changed, if the child changed the therapy, you might need to adjust it back to how it was. So these are interventions that in grade 2 might take the child back to a stable situation, to a grade 1 situation. However, we said that grade 2 can be a step, can be a stage where you can go up to grade 3 or you can go back to grade 1. That's why we really need to pay careful attention to details and to symptoms. And in this uncertain situation where you really don't know if your child is in grade 2, grade 3, there's a fluctuation in between 2 and 3, maybe at home even you can use benzodiazepines via oromucosal or clonazepam. So benzodiazepines can help a grade 2 that is going into grade 3. Those drugs can help us to not hospitalize the child. Hospitalization can be dramatic for a child, especially those who land in ICU, because also for a health, it's an emotional problem, but also a problem, it might get even worse infections in a hospital. So it's better to avoid that if it's not really necessary. And then we have the hospital setting. So if the child has been hospitalized because the situation is worsening, there you need to check what is happening to the patient. Even in this case, to eliminate triggers, it's important. Infections might not have to be treated orally, but you might do that with IVs, or you might have to change to adjust the therapy with drugs that must be done, cannot be done at home, but needs to be done with the doctor. Reevaluate the situation to understand if the child is still in grade 3 and can be dismissed from the, it's back to grade 2 and can be dismissed from the hospital, or you are going towards grade 4. And at this point, you can have an IV to try and go back to a stable clinical picture. And again, Lumsen and other colleagues are the ones who actually created this graphic, and they propose this management of pediatric status dystonicus, so hospitalized patients who have problems, in fact, with their acronym ABCD, still considers the same symptoms that we saw before. So see what the precipitants factors were to start a supporting intervention that might differ according to the situation, and might end with sedation, deep sedation, and an adjustment of the therapy or the beginning of drug therapy. Sedation. I mentioned sedation, but I don't want to give dosage. I don't want to say names of medicines and drugs. But families, when they meet with the doctors, they had to understand what kind of drugs are used. So if the doctor says we use clonidine or we use chloral hydrate, they need to know that those are drugs that are used to sedate and to control the status dystonicus. On the right side of the slide, you see antidystonic drugs that are used regularly. And they're often used in patients with GNAO1 mutation, also dopaminergic, and so on and so forth. All the names that you see on the right side of the slide, like clonidine, gabapentin. Gabapentin, for instance, can be introduced when the child comes out of the status dystonicus. The therapy can be adjusted with gabapentin, or is widely used at home too, to control sleep or other situations that, again, can be monitored and controlled at home. This is a review. This slide is about the recent review of our status dystonicus, and I wanted to stress how all the things that we said are reported in the review, so adding new drugs or 2 or 3 drugs, or what interventions like sedation, benzodiazepine, or deep sedation, what was used in status dystonicus for the treatment of the status dystonicus. So I will conclude saying that then we should talk about the outcome of the status dystonicus that we should consider. And we know that GNAO1 patients, as we said before, are more prone to this worsening that can bring them to status dystonicus. We have to consider what kind of recovery these patients have. Is that a partial recovery? Is a full recovery? And we do not know the outcome of all the situations that we considered. You might recover fully, you might not recover at all. You see, we have different graphs, different outcomes. You might have several status dystonicus, and then you recover, or after each one of that, your basic condition worsens. So these are all possible scenarios, but that we don't know about. What the result of our most recent review is that surely after a status dystonicus, the first few months, there is a higher risk to have another status dystonicus. We don't know what this what's the cause of this. We don't know if it's basic pathology, if it depends on the therapy, on the combination of drugs. It's not always easy to identify the causes. And with this, I conclude. Thank you.